Okay, this might have to be two separate recordings because I have people that are coming over later. Socially distant, though, so that's good. Anyways, what I want to go over are two papers. This one called Successful Treatment of Adult Onset Dermatitis Herpetiformis with Low-Dose Naltrexone, excuse me, and this also one called Depression, Another Autoimmune Disease from the View of Antibodies. So what I want to go over is these endorphin, which acts upon the opioid receptors. Whenever you take opiates, they are interacting with the same receptors that the endorphins are recepting on or acting upon. Those have an extremely important role in immunity, regulating the immune function, and then also preventing autoimmune disorders, right? And so, let's say, and I should also back up a little bit. Beta endorphin is a peptide that is a part of a larger protein called the POMC, the pro-opiomelanocortin protein. And this protein gets split up into its different peptides, and then these peptides are used for different functions throughout the body, beta endorphin being one of them. Corticotropin, or ATCH, is a different peptide from this POMC protein. And so, we know for a fact that influenza and coronaviruses are able to modulate the immune system by mimicking corticotropin. So they are able to mimic corticotropin, and so when your body produces antibodies against corticotropin, or when your body produces antibodies against the virus, which is mimicking corticotropin, those antibodies will actually attack the body's corticotropin, which results in a pro-inflammatory response. Okay? So, if you could imagine, corticotropin, one of the downstream effects of it is the release of cortisol, which is a stress hormone, and it's anti-inflammatory, and it helps suppress the immune system, and it's a highly regulated process. But if you produce antibodies against ATCH, then you have dysregulated your cortisol, and as a result, you can go into a more pro-inflammatory state, which is part of the symptomology of catching influenza and coronaviruses. And so you end up being symptomatic and spraying. You're more likely to spray the virus particles after your immune system has turned into a hyperinflamed state. So we like to think that if, oh, my immune system is functioning great, my immune system is like really powerful. Well, that isn't always the case. That is not what you always want in order to avoid serious symptomology, right? So we know that corticotropin is one of the targets of viruses. To me, it's not a huge logical leap to say that perhaps the other peptides on the POMC protein might also have molecular mimics in the virus world. Because, why would I believe this? Well, for one, beta endorphins also play a very similar role, coming from the same protein, but they play a similar role in the modulation of the immune system to prevent it from getting too powerful. So one of these two papers, I want to bring them up to show, one, that by modulating beta endorphin activity, we can therefore create a treatment for certain autoimmune diseases, right? So that's one. The second is that there is reason to believe that antibodies against beta endorphin are present in the body, and when they get dysregulated, then clinical depression is one of the one of the side effects of having an autoantibody response against your beta endorphin hormone. So this is a paper in Medical Hypotheses, so it's not a theory, it's just a hypothesis. But these people, Peisong Cheng, Tan Jiang, Wan Ouyang, wait. Is that Juan or Juan? I actually don't know. I'm assuming that they're also Asian. I'm sorry. I don't mean to be, what would the word be, tone deaf, but yeah, I would assume that this is not Juan. That might actually be Juan or something like that. Regardless, this group are presenting the hypothesis that autoimmune diseases are causing things such as depression, such as the attack on beta endorphin. So this is just one of the hypotheses I want to bring up, and then in a later video, I'll probably go over a video or go over a report where we do see how the autoantibody response against beta endorphins can play a role. Actually, I think I already did a video on that. I already did a video on that. So, but that was for the purpose of depression. Oh, have I already gone over this entire? You know what? I'll go over this just so that we can learn more about this. Okay. Anyways, let me see. Okay, well, I need to do a different, this is just the introduction. I actually need to go entertain some people now, but I will continue this momentarily. And we're back. Sorry about that. Anyways, now let's go through this paper. So, successful treatment of adult onset dermatitis herpetiformis with low dose naltrexone. So, what is herpetiformis? Let's look this up just so that we all are on the same page. You know what? I'm also going to do Wikipedia to make sure that we are using public domain images. So this would be Dermatitis Herpetiformis. So a chronic autoimmune blistering skin condition characterized by blisters filled with watery fluid. They're intensely itchy, and it's a cutaneous manifestation of celiac disease. So people who have the autoimmune disease where they are allergic to wheat products, and with an enteric or a digestive component of that autoimmune disorder, that is referred to as celiac disease, right? So, but there can be multiple manifestations of autoimmune diseases, not just in one particular organ. And you can see here in the skin, you can have a different autoimmune disorder. Okay? And I believe it's called herpetiformis because it takes the form, or it looks like herpes. So here they're saying it's a characteristic rash that resembles herpes, and is the basis of its clinical name. So if you end up getting this, you might not necessarily have herpes. You could just be lucky and have an autoimmune disorder instead. Anyways, now that we're on the same page, the abstract, and this is a case study, so we are following one person, one particular case, to see what can be done in this particular case. Anyways, dermatitis herpetiformis can be refractory to a gluten-free diet in up to 2% of patients, and refractory means that it is persistent. Let's just look up the definition. So stubborn or unmanageable. So here we have a stubborn or unmanageable rash that is, or skin lesions that are a result of celiac disease. And even after going on a gluten-free diet, up to 2% of patients will still have the skin lesions. Okay. So a celiac disease patient with diet refractory dermatitis dermatitis herpetiformis was treated with low-dose naltrexone. And what is naltrexone? Well, naltrexone is a opioid antagonist, right? So sold under the brand name Revia, and Vivitrol, among others, is used as medication used to manage alcohol or opioid dependence. So how does it do it? It is antagonizing the opioid receptors. And by antagonizing the opioid receptors, it can make it so that if someone does relapse, and if someone does end up taking opioids, then and if they are persistently taking naltrexone, then they will not receive the same effect from that opioid. So this can be beneficial in helping prevent dependence if someone's trying to detox. And this naltrexone should not be used before detoxification because this is after the detox process when you want to keep people off of opiates. But the process of getting people detoxed requires it needs to be done in steps. You need to slowly wean people off of opiates because what's it called? What is it called when you get off the dependency, or shoot, what is the name of it? When you are detoxing? The withdrawal. Okay, yeah, sorry about that. The withdrawal symptoms can be deadly, right? So we don't want to be prescribing an opioid antagonist to someone who's in the process of weaning off of their opioids or still going through the detoxification process, because that could make the withdrawal symptoms worse, right? So it can be taken by mouth or by injection, and the effects begin within 30 minutes. And you need to have repeated use, consistent use, in order for this to work effectively, right? Anyways, so this is naltrexone, and continuing, a randomized controlled trial showed that short-acting opioid antagonist is effective therapy in Crohn's disease. So keep this in mind. These are short-acting antagonists. So it's binding to the opioid receptor, but not activating the opioid receptor. And when it binds to the opioid receptor, it takes the place, or it prevents opioids from snuggling in to the opioid receptor. Okay, but remember, this is short-acting, so it doesn't last for a long time. Okay, and it's an effective therapy in Crohn's disease and fibromyalgia. The patient's skin lesions were present for 2 years, so 2 years of these skin lesions. That is miserable. That would be quite a hard existence to deal with. I mean, let's just go back to the photos. Like, could you imagine having rashes like this for 2 years? That would be so difficult to handle with, and that can cause a lot of psychological issues as well. That can cause people to feel self-conscious about their skin. That could make people not want to participate in social activities, which could result in like social disorders as well. So keep in mind, taking care of people's physical ailments is an extremely important role in getting people functioning in society. If people have Crohn's disease, if people have these physical ailments that prevent them from functioning in society at their best, they don't just suffer from the physical ailments, they suffer from the societal ailments as well. Anyways, I'm a broken record right now, but continuing. The patient's skin, oh yeah, so they were present for 2 years, but they went into complete remission within 3 months of taking naltrexone. We theorize that gluten-associated antigens activate long-lasting memory B lymphocyte cells that produce autoimmune antibodies, and this may perpetuate Dermatitis Herpetiformis. So there are many different types of immune cells in your body that produce many different types of antibodies. And some of the antibodies, some of the immune cells are short-lived. They act in a very acute manner. They will run to the source of the infection and create fast-acting antibodies. And those antibodies hopefully will go down to a basal level after the infection, right? But in the case of long-lasting memory B lymphocyte cells, these will produce antibodies for a very long period of time. So when people have lasting immunity to a disease, it is often utilizing the memory B lymphocytes as the producer of these long-lasting antibodies. And granted, they can be also, those antibodies after an infection, it'll increase for the infection and it will decrease down to a basal level afterwards, after the infection. But what happens when you have an allergy to something? Well, an allergy, even though it's not a disease, it could just be a tiny bit of a protein that you happen to be interacting with that just gets your immune system riled up. If that happens, then you can start getting inflammation and you can start getting damage when your body's trying to fight off this protein or this peptide or this antigen that it thinks is the worst thing ever, but even though it's not. And this is how things like Crohn's disease, or sorry, celiac disease can start, okay? But it is not just in the intestines, it is not just where the food is at. If you get your immune system riled up and antibodies are being generated against the food, sometimes, and this is very unfortunate, sometimes those antibodies can attack a different protein that is within your own body. And if that happens, the memory B cells will always be activating. They will perpetually want to be activated, and they're receiving these inflammatory signals to remain activated because that protein is within your body. Whatever that antigen is, there's something, whatever antigen was in the gluten, it was similar enough in the humans, in your human host, that that the antibodies can attack that as well, and by proxy, those antigens can activate the memory B lymphocytes into producing more antibodies. Okay, so what can be learned here? What if we are going to a hyper-inflamed response, even if it's a localized response on the skin? What is something that can fix that? Well, endorphins produced through upregulation by low-dose naltrexone may reduce this B cell activity because endorphins play a role in modulating and regulating immune activity. Okay, so let's go into this. So Dermatitis Herpetiformis, or DH, is a chronic recurring skin disease and present with pruritic papulovesicles. So I believe this means full of water, but I'm going to look this up just so that itchy. Okay, so they are itchy papulovesicles. So that's the blisters. Papulovesicles. Gosh, why can't they just say blisters, right? Having both papules and vesicles. Let's see this. Yeah, a raised area of skin tissue that is less than a centimeter around. So I guess they're designating the size because a blister could be large. Okay, so if you get these lesions, you're getting a bunch of little bumps, less than a centimeter in size. Anyways, you're getting these itchy bumps, mainly on extremities and buttocks. It is usually associated with celiac disease, although non-celiac gluten sensitivity syndrome has been reported to cause dermatitis herpetiformis, which is why sometimes people are asked to go on a gluten-free diet for a period of time and to monitor their own symptoms to see if there is a change in their general well-being. Because maybe someone doesn't have celiac disease, but they might have a gluten insensitivity. Well, going on a restrictive diet temporarily might be able to give you clues whether or not that is the root of your symptoms. Anyways, this dermatitis usually responds to a gluten-free diet, but when this fails, the only treatment option is long-term dapsone. So what is dapsone? It's an anti-infective medicine. Let me go to Wikipedia. As an antibiotic commonly used in combination with these for the treatment of leprosy. It is a second-line medication for the treatment and prevention of pneumocystis pneumonia. Okay. Additionally, it has been used for acne and dermatitis herpetiformis and various other skin conditions. I'm interested to see how does it work. So mechanism of action. As an anti-inflammatory, dapsone inhibits myeloperoxidase H2O2 halide-mediated cytotoxic system in polymorphonucleosides. Oh, I see. So this is the enzyme that basically makes bleach. Okay, so this is the enzyme that will turn hydrogen peroxide into bleach. And that bleach is going to be basically destroying everything in the area. So this is one of the defense mechanisms. If you do get infected, maybe your immune system wants to produce bleach in that area, because this is a hypochlorous acid. So this is bleach is sodium hypochlorate, or sodium hypochlorite, and so that is the salt, the sodium salt of hypochlorous acid. And so your immune system produces hypochloric acid with this myeloperoxidase, hydrogen peroxide halide-mediated cytotoxic system in polymorphonucleosides, so another type of immune cell. So what does this tell you? This tells you that your immune system, one of the ways it can get into this hyperinflammatory response and could start attacking everything because it just wants some relief, and it wants to kill whatever's in the area, and your body starts producing bleach in your skin, and then that bleach in your skin ends up causing this dermatitis. Okay, so going back to this long-term treatment with dapsone, now is that something, let's say you have this autoimmune disorder, do you want to be subjected to long-term medication use? That can affect quality of life, because all medications come with their own set of side effects. So if we can find a better, a more well-tolerated drug for a disease, that can be extremely beneficial for the quality of life of the patient. So continuing, patients with dermatitis herpetiformis and celiac disease share the three features: same histocompatibility antigens, presence of circulating immunoglobulin A against transglutamase autoantigens, and clinical remission on a gluten-free diet. Both diseases exhibit tissue transglutamase-specific autoantibodies in the small bowel mucosa, where B lymphocytes are first activated. Okay, so these diseases exhibit tissue transglutamase-specific autoantibodies. So this would be so transglutamase is an enzyme that will, if I remember correctly, will move an amino group from one amino acid into another. So it can also be used as meat glue, just so you know. So enzymes in nature that primarily catalyze the formation of an isopeptide bond between carboxamide groups of glutamine residue side chains. Okay. Lysine and glutamine residues must be bound to a peptide or a protein so that this cross-linking between separate molecules or intramolecular within the same molecule. So let me just look at this real quick. So you have, oh, that's interesting. I'm learning more. So this is actually an enzyme that will polymerize amino or peptides together by fusing a glutamine with a lysine. I mean, that's what I'm under. So here you have your glutamine, and your glutamine has the amide group on it, and then you have this lysine over here, and then you can fuse these together, and you have the glutamine uh, with a covalent bond to the lysine, and you release an ammonium group. So that's why it's called a transglutamase. I believe that this is the same transglutamase that they're talking about here. Okay, and people with dermatitis herpetiformis and celiac disease uh, have the presence of circulating immunoglobulin A. This is a type of antibody against transglutamase autoantigens. So these are antigens that are on the transglutamase that must also be similar with some antigens that are in gluten. Okay, so this is the problem that arises when the food you eat has peptides that look very, very similar to you. And if you are unlucky enough to produce an antibody against that peptide, then it can come and attack you. And for in the case of celiac disease and dermatitis herpetiformis, the the enzyme that is being attacked by the autoantibodies is the transglutamase enzyme. Interesting. Anyways, duodenal mucosal immunoglobulin A was absent in all 5 gluten-free diet refractory and 7 out of 8 control patients, which suggests that immunoglobulin A is being produced elsewhere in the body. Okay, so remember, this is the gluten-free diet refractory. So when these people are on the gluten-free diet and they still have the dermatitis herpetiformis, and they look into the intestines or if they look into the bowels to see if the antibodies are there, they're not. So that's good that it's not there. But this means that the antibodies are being produced elsewhere in the body. So we hypothesize that gluten-associated antigens produce long-lasting memory B cells in the reticuloendothelial system, and this causes autoantibodies and persistent dermatitis herpetiformis. So I don't remember exactly what this system is. It might just be one of the immune systems, often associated now with the mononuclear phagocyte system. Yeah, so it's just a subset of your immune system. I won't go into too much detail. And this causes autoantibodies and persistent dermatitis herpetiformis. We theorize that endorphins produced by the rebound effect of low-dose naltrexone may reduce this B cell activity and could be effective therapy. So they're hypothesizing that based on beta endorphins' ability to regulate B cell activity, that if we give an antagonist, an opioid antagonist, frequently your body will fight against that antagonist, and then there will be, for lack of a better term, a relapse of this endorphin trying to make up for the deficit. So remember, your body is always trying to maintain homeostasis. So whatever drugs we end up giving to the body may the body may attempt to regulate against that. So if you have a long-lasting drug, you might think, oh yeah, if I just double the drug activity, if I double the dosage, then I'm going to get double the activity in the body. And that's not true, because oftentimes the body will fight back against whatever you put in it, because that's the part of maintaining homeostasis. So you have all these regulators and positive and negative feedback loops, which help maintain the natural order of your body. So this is why we need to be mindful of what drugs we're giving, and why when we go from in vitro experimentation, where we just do tests on a few cells, that might not translate to an in vitro model, or sorry, an in vivo model, because the real body will possibly fight against it. But here, we recognize, we pay respect to that explicit fighting back of the system, and so we use that to our advantage. This is the hypothesis. We give the low-dose naltrexone, the low-dose opiate antagonist, and remember, if you were to give this a lot and maintain it at a high level, you would have the opposite effect, right? You'd be antagonizing all of the endorphins, and you might actually make the disease, the dermatitis herpetiformis, far worse, because you are attacking the endorphins, for lack of a better term. But if you do it as an impulse, the body fights back, produces a lot more endorphins, and then this naltrexone will be flushed out of the system within a few hours. Sorry about that. So then your body fights back and produces more beta endorphins to make up for the deficit. Okay. So here's the case description. A 37-year-old Caucasian woman with a past medical history of chronic joint pain from Ehlers-Danlos syndrome had a 2-year history of pruritic vesicular rash with underlying erythema, and that's like a redness on the extensor surfaces of her knees and elbows and the dorsal surface of her neck. She also had a 2-year history of postprandial bloating and allergist-diagnosed celiac disease by an abnormal TTG antibody level, although duodenal biopsies were not obtained. Gluten-free diet was initiated, and the abdominal bloating resolved. So she went on a gluten-free diet, and that did help significantly with their symptomology. Continuing, vesicles on the knees and elbows disappeared, but the arrhythmia persisted. The neck rash and the itching continued. Expert review of the photograph determined the rashes were characteristic of dermatitis herpetiformis. So luckily, these images don't seem nearly as bad as the other photos that I was showing to you. Regardless, the patient had general concerns about her disease and was evaluated by a gastroenterologist. Duodenal biopsies and TTG levels were normal, so they did not see the autoantibodies in the bowels. Owing to prior experience with LDN, giving pain relief to Ehlers-Danlos syndrome patients, and with the internet-based observations that dermatitis herpetiformis is responsive to LDN, naltrexone was prescribed. So dosing started at 1 milligram per day per OS. 1 milligram per day per, I don't know what that means, and was increased by 1 milligram every 4 days to get to 4.5 milligrams per day. After 2 weeks, the patient reported improvement in neck irritation and resolution of the redness on her knees and elbows. At the 2-month visit, the lesions had nearly resolved, and at the 3-month visit, there was complete resolution. Imagine having this for 2 years, and then it is completely resolved within 3 months. That would be such a blessing. Anyways, the patient had continued LDN for over 2 years without recurrence of dermatitis herpetiformis, and has noted improvement in the Ehlers-Danlos syndrome joint pain. Really. So here's the discussion. Chronic relapsing pruritus and papullovesicles are the hallmarks of dermatitis herpetiformis. The diagnosis can be confirmed by histology and immunofluorescence, showing granular interglobulin A deposits in perilesional skin, as well as detection of autoantibodies against transglutamase. Celiac disease is the primary cause of dermatitis herpetiformis and is an autoimmune disorder related to recognition of peptides by HLA molecules. Post-translational modifications required for optimal peptide bonding and immune mechanisms which lead to tissue damage. What is HLA molecules? Let me look this up. The human leukocyte antigen system. Okay. The major histocompatibility complex in humans. Okay. B cells are responsible for autoantibody production in celiac disease. Autoimmune disorders such as diabetes and thyroiditis may appear after celiac disease has been diagnosed and treated with a gluten-free diet. So that, I didn't know that. So it seems to be possible that these autoantibodies don't just cause these skin lesions, but they might be causing damage in the pancreas and in the thyroid. So, I mean, it might be causing effects all over the body, right? And you will only go into a doctor if you notice the symptom, right? So it could be that a lot of people who need to be on a gluten-free diet, they might be experiencing pain, damage throughout their entire body and be completely unaware until they show a pathology somewhere. Fascinating. Continuing, adherence to the diet may have no effect on the progression of these disorders, suggesting other factors are involved. So yes, if you go on a restrictive diet to help remove these antigens these allergens from you, then it is possible that a lot of the acute effects of that autoimmune disorder can be alleviated immediately. But there are long-term consequences to autoantibody attack. So we need to be vigilant on whether or not we need to be vigilant in fighting these autoimmune disorders from all fronts. Anyways, conclusions. This case report demonstrated that gluten-free diet refractory dermatitis herpetiformis could be placed into remission with LDN. With LDN. Randomized controlled trials showed that low-dose naltrexone is effective in other inflammatory diseases, including Crohn's disease and fibromyalgia. We theorize that gluten-associated antigens produce long-lasting memory B cells that lead to continued autoantibody production and refractory dermatitis herpetiformis. Endogenous opioid peptides, such as the enkephalins and the endorphins, are present in the gastrointestinal tract and endocrine system and help modulate immune responses, including B cell production. Upregulation of tissue metenkephalin and opioid receptors can be induced by a rebound effect from administration of short-acting, keep in mind, short-acting, low-dose naltrexone. If we used a long-acting antagonist, we would probably get the opposite effect. Okay. Anyways, the endorphin metenkephalin B cell activity has been demonstrated in cell culture studies. So this is something where we go from in vitro, a cell culture study, and we learn about the biomechanics of that system in the cell culture study. And if we can do an appropriate translation from the in vitro experiments into in vivo experiments, that is a success, right? So keep in mind, whenever we do this experimentation, going from in vitro into in vivo, we need to have an appropriate mirroring of the in vitro experiment. Frequently, we can do an in vitro experiment, and then if we try to do a different experiment in vivo, sometimes some of the important factors of the in vitro experiment are not being considered when we move to an in vivo experiment. So, for instance, just talking about the hydroxychloroquine studies. So a lot of those in vitro usually are controlling for ionic activity of the cell culture medium that the cells are growing in, right? So if you could imagine, these cells are perfectly fed, have all the nutrients that they need, and are basically fine. And when they are given the hydroxychloroquine, we can see the cells are far more able to defend themselves against viral replication of the SARS-CoV-2 coronavirus, or I shouldn't say SARS-CoV-2, of SARS coronavirus and other types of viruses. So not just SARS. So we have very good reason to believe that there is an effective strategy in using hydroxychloroquine. However, um, we need to understand the mechanisms of how these drugs work. Because, look, for instance here, low dose naltrexone. Well, if I decide to use a high dosage or repeated dosages of naltrexone, I would probably end up with the exact opposite uh, conclusion. And likewise, in these hydroxychloroquine studies, if the mechanism has to do with shuttling of zinc ions in and out of the cell, then if someone is, say, deficient in zinc and they're given hydroxychloroquine, that could probably make their condition far worse, because then it is, rather than shuttling zinc into the cell, it might actually be shuttling zinc out of the cell, after the cell has gone through great lengths to maintaining the zinc within the cell, especially if you're deficient, right? So this is why I haven't put a lot of stock into the really shoddy hydroxychloroquine studies yet, but hopefully we get a double-blind, randomized trial including zinc soon. That's my goal. That's my hope. Anyways, let's continue. And then this one, depression. And I also want to go over this one, depression, another autoimmune disease from the view of antibodies. So this is, I want to talk about this because to highlight the importance of autoimmune diseases when it comes to other clinical diagnoses. And one of the reasons why I'm fearful of a highly pathogenic strain of coronavirus infecting the population as a whole is the long-term effects, such as autoimmune responses that are caused by the high dosage of viral proteins all at once, especially if those viral proteins are mimicking, for one, if they create a very strong inflammatory response, that is going to have a lasting impression on your immune system, including your autoimmune system if you are unfortunate enough to have an autoimmune response. And then two, the viruses often are mimicking peptide hormones within your own body as an evasion strategy. Okay, so this evasion strategy is beneficial for the virus in trying to get you to become symptomatic later. And by making you symptomatic, you end up making it easier to get the virus from you into the new host. For one, if you're sneezing a lot, if you're coughing a lot, if your nose is running, if you are leakier, for lack of a better word, then all of that will work in the favor of the virus. So viruses will make you frequently create autoantibodies against your own regulatory peptides. And you would hope that after you've fought the virus, that those autoimmune autoimmune antibodies will go down rapidly, okay? While hopefully maintaining the non-autoantibodies at a decently high level to protect you from the next infection, okay? So this is my concern, is that I know that there are places on, I did this in my amino acid sequence study a few videos back, there are places on the SARS-2 coronavirus spike protein that do look very similar to multiple peptides on the POMC propeptide protein, right? So the One of those is the corticotropin, which we know coronaviruses and influenza will mimic. I had another. There was another one which was the NPP, or the N-terminal peptide of the POMC, but just NPP for short. And we do know that if you make antibodies against that, or we do know that this peptide is associated with the inhibition of the release of prolactin. So if you make antibodies against that, you might start releasing a large amount of prolactin, which we do see that in, like, very significantly. We see a higher expression of prolactin in people with COVID-19. Okay, so, and apparently, I just remember reading one of a paper. Like, granted, I don't believe it was fully peer-reviewed yet, and I don't believe a lot of doctors are looking at prolactin, but there was one study that's in the process of peer reviewed now that came out of Wuhan, China, that said, yeah, the prolactin is very significantly increased in people with COVID-19. So so that was a verification of my theory. And then also, what was I gonna say? Also, beta endorphin is a part of that same protein. So it doesn't, it's not crazy for me to believe that beta endorphin is also being attacked in some way, especially since the cleavage sites of the spike protein align pretty well with some of the cleavage sites of the POMC molecule. Regardless, what else do I want to say about this? We might have a mental health crisis that is associated with a bunch of people contracting SARS-CoV-2, because for one, we saw this in the SARS survivors. So SARS-CoV-1, a lot of people following their disease had serious psychiatric disorders 30 months, even 30 months after they've recovered. So what is this? For one, post-traumatic stress disorder was the main one, which makes sense, especially since oftentimes if you caught SARS, you probably lost a loved one to SARS because of how transmissible it was. But I digress. My fear right now is if a bunch of people start making autoantibodies against beta endorphin, that could be a method by which the viruses try to increase the inflammatory response of the body. Because if you sequester the beta endorphins with antibodies, then, as we saw in that case study, the inflammatory response was far greater. It was far higher than it normally would have been. Okay, and only after using naltrexone to increase the native beta endorphin in the body, that was when the inflammation stopped. Okay, so my fear is the virus exists, it mimics beta endorphin, and then the immune cells make antibodies against the virus that cross-react with the beta endorphin. And when that happens, you become more pro-inflammatory, at least for a while. For a while, you'll become pro-inflammatory, and that might cause some symptomology that helps the virus spread. So that's one thing. But a long-term effect that I worry about is depression and psychiatric disorders that are the direct result of autoantibodies against these peptides. Okay, so I'll read through this. I might have to leave again, so I'll have to splice a lot of these videos together just to have a coherent thought. But anyways, summary. Immune dysregulation is very common in major depression patients, MD patients, with these individuals incurring increased risk for development of chronic inflammatory disease or autoimmune disease. Meanwhile, depressive symptoms have been found at a high prevalence in autoimmune disease. Excuse me. This apparent convergence suggests that they may share a common pathogenic factor, or a close interaction innate. Not the wording I would use. So recent studies have found that autoantibodies autoantibodies are antibodies that attack yourself, that attack something within your own body. So that these autoantibodies play an important role in the pathogenesis of depression, both in animal models and human. Here we suggest that depression in nature can be regarded as autoimmune disease caused by various autoantibodies, which broaden our understanding of depression and brings about a new field of research in clinical implications of the disease. Okay, so let's go. In clinic, autoimmune disease and major depression share a lot of common manifestations, like familial occurrence, right? So there's a lot of genetic factors at play, right? So people could assume if you are raised in a similar environment, your psychology might be similar based on a similar upbringing, but it's not just the familial occurrence, there's also genetic predisposition, progress from subclinical to clinical, so this is important. Some diseases will have a progression of symptomology. So you'll go from a subclinical state into a clinical state where it actually needs to be addressed, right? So what are things that could cause that? Well, it's probably a gradual ramping up of whatever that underlying cause is. Continuing, female dominance. So females have a much higher risk of autoimmune disorders, and they're also at a higher risk of major depression. Okay. So that could be a hint or a clue as to whether or not there is a correlation that needs to be addressed there. Continuing, exacerbation remission pattern and laboratory abnormalities. So numerous studies and review articles of autoimmune abnormalities in patients with major depression have been published from 20 years ago to date. Evidence shows that depression was observed with a higher prevalence, and remember, these aren't native English speakers, I presume, especially since they're coming out of Guangzhou, Guangdong, China. So there are a few mishaps in spelling, so I apologize for that. I'm sure that in following, what would you call it? The editor would have changed those later. Continuing, with a higher prevalence in patients with autoimmune disease. Oh, evidence shows that depression was observed with a higher prevalence in patients with autoimmune disease. So there seems to be some underlying cause for both of them. Granted, playing devil's advocate, I could argue that someone with an autoimmune disease is probably going to experience more psychiatric disorders just from the lens of if you are physically impaired, you're probably not going to be able to interact with society the way that you normally would. So that could be a very easy underlying cause for both the psychiatric disorder of major depression and an autoimmune disease. But we should continue going along with this hypothesis, at least for now, and may occur with at least mild severity in up to 42% of rheumatoid arthritis patients. So rheumatoid arthritis is another autoimmune disease, and apparently 42% of people with rheumatoid arthritis have major depression. So not just normal clinical depression, but major depression. So that is, you can definitely argue, well, these people suffer just from walking. These people suffer just from moving their hands. That means that, if I had to undergo through that, I would probably also have psychological manifestations of that pain, right? But we can continue. Severity of depressive syndrome is closely related with the activity of autoimmune disease. Patients with autoimmunity are especially vulnerable to depression, but some scientists argue that this is due to the reaction of pain and suffering that is caused by the disease itself, but not a constitutive element. So, like, people are arguing it's probably just from the pain itself. It's not from the autoimmune disease in of itself. However, meanwhile, immune dysregulation is often found in patients with major depression. So it's not just from one going into the other, it's from the other going, well, it's not just a one-way street. People with major depression are also more likely to have some sort of immune dysregulation. Now, and this is not necessarily an immune dysregulation with a clinical manifestation that is severe enough to warrant that original rationale, right? Possibly. Continuing, suppressed immunity have been found in quite a lot of depressive patients, which include a shift in the lymphocyte subsets, decreased neutrophil phagocytosis, mitogen-stimulated lymphocyte proliferation, and natural killer cell activity. So patients, okay, so they basically have a suppressed immune system in that their immune cells are not working as well. Okay, that's interesting. Let's continue. And this is thought to be responsible for the immune system to escape from self-check and self-attack. Okay. So, what does this tell me? It tells me, remember what I said earlier, the immune systems, or all of your systems, are trying to maintain homeostasis. They're trying to prevent you going out of whack. So whatever is thrown at it, there's usually some dampening effect or some negative feedback loop that the body will employ. So here it is thought to be responsible for the immune system to escape from check and self-attack. So perhaps the reason why these people have depression is due to an autoantibody response. And in order to not go even further down the hole, the immune system suppresses itself. So that would be a form of self-check, right? If the immune system protects itself by shutting itself down, perhaps. Continuing. And the synthesis of acute phase However, the secretion of pro-inflammatory cytokines such as interleukin-1, interleukin-6, tumor necrosis factor alpha, and the synthesis of acute phase proteins from the liver cells such as CRP are increased in patients with major depression. So even though the immune system seems depressed, at least in the sheer numbers of the immune cells, the pro-inflammatory cytokines are higher in major depressed people. Yeah. What does this tell me? Well, it tells me a lot of things. It means that the immune system could be now granted, I don't know if they've deconvoluted the auto. So let's say there's a Venn diagram. People with major depression and people with the with known clinical autoimmune disorders. And if you do the Venn diagram, how far does it line up, right? And even if you exclude the people in the middle, do the people with major depression on average still have increased pro-inflammatory cytokines? Maybe, maybe not. So that would be a nice table to include to try to help visualize and quantify their statements, right? But they're saying that the pro-inflammatory cytokines are higher in people with major depression. And this is thought to be an indication of immune activation. Anyways, emerging evidences have shown that autoantibodies may play an important role in depression. Autoimmune thyroiditis may be the most common autoimmune disease in depressive patients. So we do know that this is a common autoimmune disorder that is in depressive patients. Significantly higher thyroid binding inhibitory immunoglobulins, or TBIs, in depressive patients compared to healthy controls suggests the presence of an autoimmune process affecting the thyroid gland. Uh, Thyroperoxidase antibodies, or TPO-ABs, during early pregnancy were found to be associated with the development of postpartum depression, really, and can be regarded as a marker for depression. So that's interesting. So I may have, I may have, I did talk about this in my previous videos, where the placenta and the fetus are immune privileged sites in which the immune system is not allowed to enter. Uh, at least it is suppressed from entering those areas. And one of the reasons is because those areas are expressing a lot of unique and new proteins that the mother's immune system has not experienced in its maturation process. So if it wasn't an immunoprivileged area, then the immune system of the mother would come into contact with the antigens of the placenta and the baby, and then possibly the generation of antibodies against the placenta and the baby would be generated. Now, this would be very bad because not only would it destroy, not only would it kill the placenta and the fetus immediately, cause a lot of a high incidences of miscarriage, but then also the proteins of the child and the placenta, even if they're not exactly the same, they can be very similar to the proteins of the mother. So not only would it attack the child, it could also start attacking the proteins of the mother and cause an autoantibody response or an autoimmune response. So here they're arguing that the production of thyroperoxidase antibodies during early pregnancy were found to be associated with the development of postpartum depression. So somehow, in a very unfortunate string of events, the immune system probably came into contact with an antigen that was expressed during pregnancy. Either it could have been in the fetus and the placenta in of itself, or it could have also been another protein that was upregulated due to the pregnancy hormones, and that upregulation of that new protein ended up inadvertently activating a poor immune cell that didn't realize that it was latching onto its own molecules. Regardless, this is a big indicator of postpartum depression, is the presence of these thyroperoxidase antibodies, or the TPO-ABs. Anyways, continuing. Antibodies to endogenous neuropeptides are also suggested to play a potential role in depression. These people have found that anti-somatostatin reactivity was significantly higher in patients with major depression. As a result, increased antisomatin immunoglobulin G. And this is as a result of the increased anti-somatostatin immunoglobulin G. Anti-nuclear antibodies and antiphospholipid antibodies were known for their pathogenic role in systemic lupus erythematosus, or SLE, and antiphospholipid syndrome. So the phospholipids, those are chemicals that make up cellular membranes, but they can also be used as signaling molecules if they're processed in certain ways. So I don't know if this antiphospholipid syndrome is attacking the cellular membranes themselves, or if they're attacking the hormones that are generated from the phospholipids. Regardless, they are playing a role in the progression of these very serious diseases. Interestingly, they were found to be present more frequently in depressed patients than in normal volunteers, and the antiphospholipid antibodies have been found associated with many neurological syndromes, such as cognitive dysfunction, dementia, psychosis, depression, seizures, chorea, I don't know what that is, and transverse myelopathy. Okay. The most convincing evidence for the pathological role of autoantibodies in depression was from the work done by Katsav and his colleagues. Uh, intracerebroventricular injection with affinity purified human antiribosomal P antibodies caused depressive behavior in mice. And antiribosomal P antibodies specifically stain neurons in the hippocampus, the cortex, and the primary olfactory piriform cortex. The antiribosomal P antibody-induced depression-like behavior was partially blocked by a specific anti-idiotypic antibody and significantly blocked by long-term treatment with fluoxetine. I don't know how to pronounce that. Regardless, I need to digest that. So, if we inject these antibodies into mice, and we know if they attack these particular proteins, and in this case it's the antiribosomal P, this can induce depression-like behavior in the mice. And it's significantly blocked by long-term treatment with this, which I believe would be an immunomodulator. So let's look this up, and I like Wikipedia. Oh, Prozac. Okay, Prozac and this, and is an antidepressant and a selective serotonin reuptake inhibitor. Oh, is this also an... Okay, well, it doesn't seem to have an easily findable role in... was partially blocked by a specific anti-idiopathic... Well, okay, so it could be blocked with a serotonin reuptake inhibitor, which would allow for more serotonin to build up into in the brain. So that's one way to do it. But it also was attacked by a specific anti-idiopathic antibody. So they probably... Yes. So basically a neutralizing antibody. So if they give the antibody and then they give a different antibody that attacks that original antibody, then the depression-like behavior is reduced. Okay, so in this particular case, you can induce depression by creating the autoimmunity in a mouse. Interesting. Anyways, the administration of anti-N-methyl D-aspartate receptor, or NMDAR, antibodies in mice can cause hippocampal damage accompanied with behavioral disorders. So if we inject the antibodies against this receptor into the mouse, it can cause behavioral disorders and hippocampal damage. And what else? So remember, the brain is at least partially an immunoprivileged site. So the immune system is somewhat separated from the brain. Now, by injecting these antibodies, we can damage the brain. And unfortunately, a lot of damage is semi-permanent, or it takes a long time to recover because the brain is slow to grow, it's slow to repair itself. The neurons are slow growing cells in general. right? So anyways, administration of those antibodies can cause the damage, and that damage could probably be, so even after, let's say you do have a response and it's an acute response and it causes some damage, well, that damage, even if the immune system goes back to normal, that damage could linger for quite some time after the fact. Yeah, continuing. In light of these findings and the clinical similarities between major depression and autoimmune disease, we propose that autoantibodies are responsible for the pathogenesis of depression, just like what they have done in other autoimmune diseases. And what could be uh, the things that are being attacked in major depressive disorders? Well, beta endorphin, that is one of them. Beta endorphin is one of the peptides that could be attacked. Granted, these people are discussing more of the receptors. If you create antibodies against the actual proteins that are existing on the cell membranes, that can cause problems and damage if you do end up having autoantibody attack against those. But I want to expand it, especially in the case of viruses. Viruses might be producing or mimicking these um, peptide hormones, which could therefore lead to an autoimmune response against those peptide hormones, even though that was not the intent of the immune system in the first place. So, hypothesis. Briefly, depression and autoimmune disease are very similar in clinical manifestations and closely related in epidemiology. These convergences can be explained by that they originated from the same pathogen. The significance of autoantibodies in autoimmune disease has been well defined. We suggest that the same pathogenesis caused by autoantibodies happened in depression, but with different targets. In this regard, depression can be termed as an autoimmune disease in nature. Autoantibodies may cause depressive syndrome through several mechanisms. Target critical glands in neuroendocrine systems such as the thyroid, the hypothalamo-pituitary adrenal axis, or the HPA axis, making them dysfunction or dysregulated. The role of TPO antibodies and thyroid dysfunction in depression has been well stated before. Interact with or block the signal transduction of endogenous neuropeptides. So this is what I was talking about earlier with the beta endorphins being attacked, which are responsible for the modulation of psychiatric manifestations. The prevalence of anti-somatostatin in depression may serve as an example. And in animal models, anti-NMDAR antibodies is the case. Still, we cannot... And in animal models, anti-NMDAR antibodies is the case. Okay. Still, we cannot exclude that other neuropeptide antibodies may exist in these patients, such as the brain-derived neurotrophic factor, or BDNF antibodies. And they can specifically bind and deposit in certain areas of the central nervous system, like the hippocampus, or these other cortexes, for example, the anti-ribosomal P antibodies. Although autoantibodies target specifically to respond to stress, functionally and maintain a good state of mood, involves many regulatory mechanisms. The actual course could be much more complicated. Anyways, evaluation and implications. The evidence that the depressive syndrome is associated with immunity is now compelling, but mainly focused on immune activation and cytokines. We propose an autoantibody pathogenesis mechanism underlying depression with a new set of testable hypotheses that will advance our understanding of depression. Our hypothesis shows no discrepancy with other hypotheses about the origin of depression, such as the HPA axis impairment, serotonin reuptake, or decreased BNDF. So it is nice whenever you make a new hypothesis that it is still consistent with pre-existing hypotheses, or at least it doesn't, well, you also want to make hypotheses that challenge pre-existing hypotheses. But what is also beneficial is when you create a hypothesis, a hypothesis that simplifies, or is a more, for lack of a better term, there is a more beautiful version or a more elegant model, a more elegant hypothesis that is still consistent with a previous hypothesis. it is nice to have the more elegant one, because the more elegant one can also might be able to produce better predictions, and then you can test those better predictions. Okay, so it's good to have a model that predicts rather than a model that you have to keep on changing to fit the data, if you will. Yeah, and that would be the difference between an overfit model, a model that is literally just changing to fit the data, which, some physicists might argue that string theory falls into that category. Or you could have a simpler and more elegant model that not only fits the data, but then, what would you call it, generalizes and is able to make predictions. A more generalizable model and a more predictive model and a more testable model / hypothesis is better, at least a better route for the scientific method. Anyways, continuing. Seeking for more reliable and critical autoantibodies in depression, what we have revealed is just the tip of the iceberg. More autoantibodies may be involved in the course. Some of them may be important in anti-ribosomal P antibodies in animal model, but remain unknown to us. Revealing how these autoantibodies generate in depressive patients, especially how they relate with stress and environment, display more details about their role in the development of depression, such as how they change the reactivity of the HPA axis or how they affect the limbic system function. Whether there is a relation between the autoantibodies and the disease severity, or healthy individuals with elevated autoantibodies will be easier to develop depressive symptoms, or the current effective treatment of antidepressants will result in the clearance of autoantibodies. In clinical aspects, the current diagnosis of depressive patients is mainly dependent on behavior measuring. Establishing a set of biomarkers, including autoantibodies, cytokines, and immune activation markers in diagnosis of depression will be much more objective and helpful. And finally, the immune system may be an appropriate target for depression therapy and antidepressant mechanisms. So, my thoughts. Well, we know for Alzheimer's that there is a, what would you call them? We've already used these autoantibodies as markers to indicate whether there is a clinical disease present. So for Alzheimer's and what's the other one? Dementia. The way to separate those two can use an antibody test, an autoantibody test explicitly. So there is a, what would you call it, a patent. There's a patent and a paper associated with the development of a test that can identify Alzheimer's and contrast it to dementia. And that uses autoantibody markers to do so, and they're autoantibodies against relevant neurological peptides and proteins. And then, so this is an important field, and it is a relevant field in that viruses are probably, and it's not just, I don't consider this a very fringe hypothesis, but viruses are frequently coming into our bodies. They are taking over our cellular mechanisms at all times. They are producing proteins that are very similar to your own proteins. And then also, they come in, they cause inflammation, and then rupture the cells within your own body. Well, that would be another mechanism by which the immune cells, especially the dendritic cells, might accidentally take up the antigens of your own body and then present those antigens to the naive T cells. And then that could be a way that your body produces not just autoantibodies that were supposed to target the virus, but autoantibodies against your own body as well. So what does this tell me? Your body has phenomenal mechanisms of destroying and attacking viruses. But nothing is perfect. Remember, biology is a noisy field. And what I do not want is a high dosage of an extreme, of a immunomodulatory virus. I do not want a high dosage of it. So the normal coronaviruses, maybe they also have these, the four normal species of coronaviruses that circulate at all times, they don't reach the same concentrations as SARS-CoV-2 or SARS. So their effect on the immune system is going to be far limited compared to them. So I have to go now, but thanks for listening, and you have a good one.